Good afternoon and welcome to our webinar. This is COVID-19 pandemic and workers' compensation. What are the medical providers thinking? We're going to hold on for a few minutes because we know that people are still streaming in, and then we'll begin. As a moderator, I get to set the focus, tone, and goals of this webinar. My hope is to make this presentation a meaningful educational experience. We are living in a very unusual and challenging time. We are all confronted with a virus that has no known cure and no preventative vaccine. In fact, of all the hallmarks of this pandemic is our lack of knowledge. We hope to offer you a break from your typical atypical afternoon. Our panelists are smart, they're well trained, and they're experienced practitioners. I'd love to tell you that we will be providing definitive answers to questions concerning COVID-19, but that's simply not possible. We will, however, offer insight and meaningful observations. We will present for approximately 45 minutes to 50 minutes, and then we will address questions for the remainder of the time. We are assisted today by Melanie Solomon and by Melissa Wright. Let me introduce our panel. With us today in audio form is Dr. Carlyle Voss. Dr. Voss brings to this discussion over 30 years of forensic psychiatric experience. He is a graduate of Baylor College of Medicine and completed his psychiatric residency at New York State Psychiatric Institute, part of the Columbia University system. Over his career, he has held a number of positions, including Director of Psychiatric Inpatient. He was a Director of Psychiatric Outpatient, and he was also a Director of Psychiatric Research. His work is now focused on forensic psychiatry, where he accepts legal referrals from both plaintiffs, and that would be in workers' compensation claimant counsel, and defendants. Full disclosure here, Dr. Voss has accepted referrals from me and when I was in private practice, and has been hired as an expert in cases against me. I always knew when he consulted on a case that the claimant was being fairly evaluated and that we would learn a great deal from his reports. Dr. Voss, would you like to add anything to this introduction?
No, that's very thorough. They're very kind, Paul. I am board certified in psychiatry and forensic psychiatry, and am a clinical professor with the Tufts Medical School.
Okay. Our second panelist today is Dr. Kenji Saito. Dr. Saito is a graduate of the University of Pennsylvania and Temple University Medical School, but also Rutgers University Law School. He is a fellow of the American College of Occupational and Environmental Medicine. He holds faculty appointments with the University of Pennsylvania and Dartmouth Medical School and the University of New England Osteopathic School. Dr. Saito is a frequent speaker on occupational medicine topics and has numerous publications. In fact, when I was putting together these introductory comments, when I looked at these gentlemen's backgrounds and experience, I thought that I was going to have to cut it fairly short, because if I gave you all the details, it would have spent most of the hour discussing what they have done and what they do. Dr. Saito, would you like to supplement what I have said about you?
No, thank you, Paul. That was really nice.
And I am Paul Sighinolfi. I came to this position having been a trial lawyer for 30 years. And during that practice, I had a focus in workers' compensation, where I represented both injured workers and I represented employers and carriers. From there, I became the executive director and chair of the Maine Workers' Compensation Board, a position that I held for 8 years. 14 months ago, I was offered the opportunity to reinvent myself. I did so by joining Ametros as a senior managing director. And Ametros is a company where we professionally manage Medicare set-aside accounts. Ametros has afforded me the opportunity to organize and moderate this webinar. I am not a scientist. I have no medical training, but I'm here today to ask questions. The two gentlemen who are with me are people that I've known for a while. I consider them both friends, and so we've agreed off the record to dispense with formalities, and we're going to call each other by our first names. Now, let's begin with our seminar. Since December of last year, when the World Health Organization told us COVID-19 was first detected, it has caused unimagined problems in our society, not the least of which are problems associated with employment. How do we adapt, and how do we create situations to prevent people from being exposed to the risks associated with this virus, particularly those who are in positions where it's very difficult to have modified position. Lyle, where are you today? Where are you working?
Oh, I have my own office where I do my work in Portland. And I'm there. I'm in it right now.
Last time you were there?
I'm sorry?
When was the last time you were there?
In my office?
Yes.
Oh, I've come in several times. Nobody else is in here. The place is empty. I was in 2 days ago, but just to pick up the mail and do some stuff that needed to be done here.
But for the most part, now you're working from home. Is that correct?
Oh yes. Staying home, avoiding contact with others. I'm in a high-risk group by age, so going to be careful. This is very serious, especially for people in my age group.
Kenji, where are you working now? I'm specific. Right now, where are you?
Yeah, I'm actually working from home now. Up to about a week ago, I was in a clinic. Things have slowed down a little bit, especially in occupational health settings, when employers were asked to keep their employees at home to stay healthy at home. So the clientele did drop a bit, and the patient load dropped a bit as well. But I do most of my consulting work now through video conferencing and technology and telemedicine, telehealth.
I have spent a good deal of time preparing for this webinar, and one of the things that I think we need to do to share with our audience today is something that I found almost none of the articles ever explained. And so I'm going to turn to you, Kenji. What is a virus?
Yeah, that's a great question. And a virus, the definition has definitely changed over the years. And people have asked, is it alive? Is it not? So I kind of put a quick PowerPoint together just to show us what that means in a few minutes. A good friend of mine from my ophthalmology training days actually did a really good painting explaining this wave of coronavirus that we're seeing, and truly is a wave, and it's affecting healthcare in a very different way. So it's interesting. So I wanted to know what that means. What does it look like? So a virus is basically a genetic material that's encapsulated, especially the coronavirus, and it's encapsulated in a way that's very unique, and unique in that it's not alive from a biological perspective because it can't replicate. In order to replicate, it has to hijack the host. And when you look at something like the coronavirus, and the reason why it's coronavirus, you can see all these spikes here. And these spikes are basically what we call an antigen that we can use to detect these viruses. And these viruses either come as DNA or RNA. And RNA is a genetic material in the coronavirus in this area in here. But also, if you want to look at the membranes here, the redness here that you can see, as well as some of the envelopes as well, highlighted here. So the virus overall is in sort of a genetic material that is not living because it needs to hijack the host to replicate itself, to survive and to be able to reproduce, but also it encourages genetic replication, whether it's RNA or DNA. So sort of in a 4-year virology class, I summarized that in like 30 seconds, and overall, that's what a virus is.
And just so we understand, how big is this thing that you're looking at here? I see your slide. Is it visible to the naked eye? I mean, that's
Absolutely
a silly question.
not. Yeah, it's super microscopic. So even with a microscope, you won't be able to see it. And this is one of the challenges we've had earlier on and understand bacteria versus virus. The virus is very small and you can't see with the naked eye, you can't see with the microscope. So you have to have other techniques to measure it.
And how is it transmitted? Where is it that people get exposed?
Yeah, so different viruses transmit very differently. So if you look at it from an interesting perspective is, where does it come from? We know now is zoonotic, meaning it actually came from an animal reservoir, especially the coronavirus. And if you look at it, the family coronaviruses exist in different ways, and it's transmitted very differently because it changes. And it's a very smart entity in that it changes one genetic code, and all of a sudden it's a different virus the following year. So a lot of people ask me too, where does COVID-19 come from? It's coronavirus 2019, because that's when we first saw it in Wuhan, China, of 2019. And that's why it's actually a family members of SARS. And if you remember back in 2003, we had the SARS outbreak. Then we had MERS in the Middle East, CoV as well. And these are all the same family of viruses that had different reservoirs that mutated over time and became exposed to humans. And in humans, as you can see on the right, it affects the multiple different organ systems. And if you look at it from a sort of population perspective, how it transmits, you can see that it transmits very differently, very rapidly. So if you look on the right-hand side, the virus is there, the row naught basically looks at basic reproduction numbers. These viruses can readily replicate quickly and infect people very differently. So when you look at something like measles, bottom right corner down here, you can see how rapidly and how infectious that is compared to what we're thinking right now of where the coronavirus and SARS is right now as well. So where does it affect it? It affects it in multiple different ways. And this is how we kind of know how infectious something is by looking at how contagious that virus is. So if you look at measles, as I mentioned in the previous slide, it's 12 to 18 times more contagious than what we know right now of 2019 coronavirus. So this is where we need to really look at it and look at it from perspective of what the case fatality rate is, meaning how fatal the disease is as compared to how infectious it is. And the data isn't quite out yet, but this is where we are today. And we need to understand the virus a little bit better so that we can get a better understanding of how it affects the human being and how does it affect us. And WHO, the World Health Organization, definitely thinks the death rate is definitely higher than what it was that we initially thought. So I think I want to skip to some slides here to show you the idea of how infectious this is. If you look at something compared to sort of the Ebola virus, this is a great slide talking about why we ask people to distance themselves 6 feet. People always ask me, where did we come up with that number? It is based in science, and it's based on the particle aerolization opportunities when someone coughs the virus up. So when you have something virus that we can't see, you can see as we move away, measles can go very far. And this is why when we have measles outbreak, it's quite contagious and it can go very far. And the protections we need is a lot more greater than something like Ebola, where it's actually falls to the ground a lot quicker. So luckily on Earth, we have something called gravity. It does pull particles down. And we can see here with something like measles or coronavirus, 6 feet is sort of the distance that we need to be at to avoid the exposure we get from these droplets coming in. We breathe it in, we eat it in, we get it on our skin, get it on surfaces, and eventually it gets absorbed into our body. So that's sort of the way that we can be exposed to viruses overall.
In preparation, reading the news has led me to believe that individuals with certain comorbidities have a higher risk for this infection. What are those? What are the comorbidities that we have to be sensitive to?
Yeah, so originally we thought it was just the immunocompromised folks, and that just usually mean if you have a weakened immune system. But we're starting to learn now in the past couple of weeks that it actually includes almost all sort of chronic conditions, such as obesity, diabetes, high blood pressure, hypertension, and most recently we're starting to see various neurological conditions as well. Age is definitely one factor, and depending on the carriers, we are seeing in different varieties as well. So there's more to come. We don't know quite sure what the total risks are, but those are what we're seeing as of right now.
Lyle mentioned age when I asked him where he was staying, and why is age an important variable here?
So I'm not sure if Lyle wants to answer this, but from a medical perspective, the way our immune response responds to different foreign antigens like a virus really depends on how your body responds. And as we age, we do become less immune prone. What we're starting to see, especially those who have respiratory conditions, age is a risk factor for inflammatory response. So I'm not sure if you heard the term cytokine storm, but that's sort of a big area right now that we're looking at, why some people are in the ICU on ventilators, whereas other people are not. And what we're starting to understand now, and the science is starting to develop slowly on this, is that the idea of a cytokine storm, the pro-inflammatory state, is quite intense in those who are in the higher age group. And when we're starting to see that those who are in a higher age group aren't able to rebound from those conditions as quickly as some of the more resilient immunocompetent patients who are in the hospital as well.
Lyle, I want to bring you into this conversation. The nightly news repeatedly tells us about the chaos associated with this virus. And it tells us about the frontline workers, and it has excerpts on the news about these frontline workers who are afraid to go to work, but they do. and they're not well protected once they go to work. From your perspective as a psychiatrist, is that something that that could cause a psychiatric or psychological response? Kenji, I'm going to go off to another topic while we're waiting for Lyle. One of the other topics that comes up if you read the literature about this COVID-19 virus in workers' compensation is the vast development recently of telemedicine. Now, telemedicine has been around for a while. It's been discussed in the workers' compensation literature for years, but all of a sudden it has blossomed. What's your take on the use of telemedicine?
Yeah, one of my students and I are actually working on a paper on this right now. Hopefully it should be accepted for publication shortly. But basically, we've had over a decade to talk about telemedicine. We've actually done a lot of research. There's a lot of policies written behind it, but we applied it within 2 weeks of COVID-19. So decades of research implemented within 2 weeks within COVID-19 has been a challenge, but at least we have sort of parameters around what that means, especially in workers' compensation, when we're seeing 80% of the cases are musculoskeletal injuries. All you need to see is, what's your range of movement? Can you move this way? Tell me how you're feeling today. Ask about functional status. Some people still ask about pain. There's questions whether that's a good metric or not. But if you're talking about function, a lot of it's communication through what we're doing like right now, but we can also see range of movements and people can show. We have technology now where we can actually do telepresence, where we can actually get a stethoscope. I can listen to your heart if you have someone that's available, the machinery available. Even with our phones nowadays, we can actually use the phone and actually find out what your heart rate is, what is your oxygen saturation rate is, what does your eye look like. Back when I was doing ophthalmology, we were able to do teleretina services through the VA system, where we had people sitting all over the US reading our retina images for diabetic retinopathy. So technology has definitely existed for decades. However, implementing it in the past about 2 weeks, 4 weeks, we went from about maybe 5 or 10% utilization of telehealth to about 70 to 80% utilization of telehealth in medicine overall. So it's definitely changing the landscape of healthcare. And of course, the payment structure eventually came along with CMS's guidance on this. We're able to apply it even more on a broader scale. But from workers' comp, I think it works really well. Why? Like I said earlier, we see a lot of musculoskeletal injuries, which we see grossly. We don't necessarily need the sort of the human-human interaction, although I think that's still important. We can do follow-up care quite well with telemedicine.
Yeah.
Hello, hi. Can you hear me now?
Yes.
Hi, Lyle. Welcome back.
How are you?
Okay. I get cut off when it goes when we use the program, so I've shut that out.
Okay. I was asking. We were just talking about telemedicine with Kenji, but I'm going to go back to you. In my comment, I don't know if you heard my comments, but I read through or I watch the news and I read through the newspaper, and all I hear about is the chaos, and all I hear about is the risks associated with going to work for people who are on the front line, who have to deal with the public on a regular basis. I know that you and I have had cases involving emotional injuries associated with employment. What about that? Is this the kind of thing that you as a psychiatrist could say that it is extraordinary and unusual stress that these folks are being exposed to by simply working as a cashier?
It certainly can be. I think if not just the cashier, but the first responders, the nurses, the doctors are working closely with the people. People who are exposed to have extra exposure to the risk of getting the virus themselves are very apprehensive about that. The situation is also compounded by the pervasiveness and the ubiquitousness, ubiquity, I guess, of the possibilities of getting infected. We know that there are a number of asymptomatic people who are carrying the virus and may infect others, even though they themselves have few or no symptoms. What is particularly difficult about this situation is the pervasive effects that it has compared to other disasters, such as the 9/11 or Katrina. Those were horrible things, but they basically affected the people immediately around them neighbors, their friends, their family. They could go into stores if they were available. We could support each other. What's happened with this situation is we're restricted to our homes generally, and when we do go out to the grocery store, we need to maintain distance, not to avoid interacting with others. This is a very unique and extraordinarily stressful situation. Even after, if one does go to the grocery store, it can be 2 weeks before you feel that you did not get the virus from that. So this situation is really difficult psychologically, and I think we're going to be seeing a number of stress problems, stress-related problems, as clinicians, as mental health workers, but also in the workers' comp system. We're going to experience a number of stress-related claims injuries, and you hear from the nurses who are on the evening news at times. They may have to deal with a number of 6 or 8 deaths of their patients on a single shift.
Yeah,
it's horrible. It's just horrible.
Let me play devil's advocate with you for a second. And as you know, I've deposed you on a number of occasions, and I was a defense attorney in some of those depositions. Doc, as I read the reports about this COVID-19 virus, it's, as you used the word a short while ago, it's ubiquitous. It's everywhere. How can you tease out that the stress that this person is experiencing at work isn't just as bad as the stress they're experiencing by going to work, by traveling to work or going to the grocery store or doing things like that? Isn't that equally stressful? And how would you tease out what stress is the stress that's causing them to have an emotional reaction? Isn't stress cumulative?
This is an issue just not for this particular situation, but for other stress-related claims, which are not unusual for the first responders, paramedics, police, so forth. And stress, post-traumatic stress, typically has a pretty clear or very clear relationship to the nature of the stress. The person develops intrusive, intense memories. They have nightmares, and the content of those is typically very clearly related to the stress. So if it was a nurse who was claiming stress related to her job, you'd want to ask about details of the symptoms, and if the nightmares involve people dying, involve her not having protection, being vulnerable, that would support the conclusion that the stress was related. If, on the other hand, there are other things that the content is otherwise, say of being injured in a car accident, that kind of thing, and the person had an accident, then you would conclude that the other trauma may have been the primary cause, or the COVID-related trauma was a contributing factor, aggravated a pre-existing condition. Taking a careful and detailed history is the most important step in these analyses.
Let me ask you this: while you were disconnected from us, I was asking Kenji about telemedicine. It has absolutely blossomed in workers' compensation over the past 6 weeks. Is that a good approach these days in psychiatry? Can you do a good initial psychiatric evaluation and follow-up treatment with a patient telemedically, assuming you have both audio and visual?
assuming I can get connected. And I have been using Zoom for other things. I have not done evaluations yet. This is all relatively new. I think the telemedicine and telepsychiatry can work quite well. I prefer to, and many of us, I think most of us prefer to see the person in person, but that's not possible at this point. I would, excuse me. You know, I'm not seeing people in my office until the quarantine is lifted in Maine, and that it's working. Again, I'm in a high risk group. People in their 70s or 80s have a death rate if they get the virus of 60 to 70%. I don't like those odds, so I'm trying to stay healthy.
Let me ask. Let me ask.
Oh, I'm sorry. Yeah, telemedicine. It's helpful.
Let me ask
Kenji. Go ahead, Paul.
If I might. Kenji, some states have worked into their statutory schemes certain thresholds that are important in order to get benefits or in order to settle cases, in order to do things like that. One of them is maximum medical improvement. Would you be comfortable doing an evaluation to establish maximum medical improvement by telemedicine rather than seeing the patient personally?
I think, especially depending on what kind of medical records available to me, I think MMI evaluation can be done through telemedicine, because as long as the records are there, all the specialists has contributed their medical opinions. Most of it, almost I would say 80% of it, comes from the medical records itself, and 20% of it is from evaluation of the patient or the claimant. So if I can actually do an evaluation like through what I'm seeing now, I can see them visually, depending what the conditions are. If it's a skin rash or if it's a chronic condition, somewhere I can see and talk, I think that's not an issue at all. And actually you can perhaps even do permanent impairment rating as well, because a lot of it, especially Maine, if you're using the 4th edition, as long as you can see and measure your range of movements pretty well, you can actually do a pretty good impairment rating as well as determining MMI.
Okay.
Absolutely.
I'm going to ask both of you gentlemen.
Yeah, let me take a little different view, because in psychiatry, I would say that the history I get from the person is extremely important. And what's in the medical record typically, often is just what the person has been willing to tell the provider, or the provider has seen fit to include in the record. And I just had a case where what was in the record was substantial, and what the person told me was substantial variance from other very reliable information that the person had been physically much more active. But I would agree with Kenji in his field that the medical records are objective. They're physical problems. In psychiatry, it's multifactorial. So the interview can be extremely important.
No, I agree. And I think especially with some of the multifactorial cases, I do appreciate when I read Lyle's report about, what the psychiatric sequelae are, and the neuropsychological evaluation as well, because those are left best for the specialists. And once we have those reports, we can actually tabulate them all together so we can see the body as a holistic view to be able to look at some of the MMI assessment as well. So we do need a combination of both, like a hybrid approach.
An example would be if the primary care person asks a patient if she's suicidal, she may say, "Oh, no." When I ask the patient, "Are you suicidal?" she says, "Oh, no," hesitates, "Not really." Well, that tells me that there's a lot more going on there than she's admitting to. But in the record, it says not suicidal.
Okay. Yeah. Let me continue on to a different area here. One of the topics that jumps out in recent months associated with the COVID-19 virus is that over the last couple of years, states have been carving out very specific statutory provisions to deal with certain unique populations. And probably at the head of that class would be the first responders, the police officers, the firemen, the ambulance technicians, some of the people in the emergency room, people like that. And they've been giving them presumptions, preferential treatment under the statute. In recent weeks, there's been a flurry of activity across the country. Illinois, Washington State, some places down south have been granting very special presumptions for people who hold certain positions and are alleging that they have contracted the virus. What do you think about that from a medical perspective? Do you think classes of employees should be given preferential treatment, or should it be that the exposure is a significant determinative of whether or not there's a causation opinion that could be rendered? Kenji, what do you think?
So it's interesting because one of the other articles, actually another student on my writing on, is the cancer presumptions for firefighters. That should be submitted soon as well. So hopefully that should be published within the next couple months. And there we found the same thing. Should the firefighters have specific carve out in the legislation about presumption for different cancers that develop 20 years later? That's a little different because here with the coronavirus and COVID-19 specifically, we're seeing the impact immediately. And the first question I had was, how is this different from any other exposures like hepatitis B or bloodborne pathogen exposures that we would measles we get with HIV, other viruses that we have exposures to? And it's not really too different if you think about it from an infectious disease perspective. The difference here, however, is we don't know how to diagnose COVID-19 like we do with antibody testing, like we do with hepatitis and HIV. But once we get there, I think the need and necessity for presumptions might dissipate. However, in an unknown sort of atmosphere we're in right now for the foreseeable future, the presumption does help from a medical perspective because finding causation is going to be tough when you have community-wide spread. For example, how do we know this virus was caught during working hours and furtherance of the employment, or was it caught going to the grocery store, going to the local outlets as we start to reopen the economy? That's really hard to tell because we can't distinguish from a diagnostic test when and where that point of contact happened. However, we are getting better with contact tracing. And a lot of the public health officials now have been doing better idea of how to do that. So that gives us an idea of causation from the perspective of the mechanism of injury. However, it still gives us a challenge. There are different classes of jobs that allow us to say, is this in furtherance of their employment or not? Or did they catch this in a community-wide spread environment? So that's challenging. So the presumptions help us in one way in that it does take away that one factor, but gives a lot of different factors. But as we get better diagnosis, I think that the methodology we have in place now from the medical causation should be sufficient once we have the appropriate diagnostic testing to allow for that.
Let me follow up on your comment about contact tracing. We know that Google and Apple have decided to team up and try to help us in that regard. Epidemiologically, is that just make good sense?
I think so. I mean, I'm a big fan of technology only when it works. So the key is, how is that happening from one perspective? But when I put the lawyer hat on, the question about privacy comes about too. Because once you do contact tracing, and if you're going to use your cell phone, nowadays, everything's on my cell phone. If they have access to it, what can't they access on my cell phone? If you have GPS, I'll know where you're at. We can link to geosynchronous timing so we know exactly when and where you were, certain time, and who you were exposed to. There's a lot of apps out there now. If you actually go through the privacy settings, you'll be amazed what you're sharing with them. It's your contact lists, your pictures, your information on what emails you receive, how often are you on your screen, how many times are you using your phone? I mean, the last data shows we're on our phone almost every 20 seconds. It's amazing how often we're using it. And if data can track all that with big data, privacy is a big concern for me. But I think the idea from a real utopian view is that great. From a public health official, I would love that because I want to be able to see and be able to trace and say, hey, you contacted this person, so we should reach out to them and let them know, hey, you know, even though you haven't been diagnosed, it's easier to presume that you might be positive now because your duration might have been at least 10 minutes. Some people say duration should be 30 minutes, but we now know between 10 to 30 minutes is significant enough to say that is a contact and that trace should be considered, you know, tested positive. Then others who are exposed in that tracing should be notified, and those are the people we should put into quarantine. So it does help us.
This allows me to segue nicely into the next area that I want to explore with you two gentlemen, and that is in order to better understand how people pass on disease, I started reading about this incident or series of incidents in the early 1900s in New York City, where there was this cook who was very famous for making peach ice cream. And she was going from wealthy family to wealthy family making peach ice cream. And people never correlated it until after the fact, but people were then coming down with typhoid. And she ultimately got the label of Typhoid Mary. And Typhoid Mary was absolutely asymptomatic. Do we have Typhoid Marys floating around with the COVID-19 virus? Miles, what do you think? Technology is wonderful when it works.
When it works.
Kenji, you want to pick up on that?
Sure, absolutely. I think Lyle kind of alluded to this as well when he was talking about the asymptomatic folks. And a lot of the questions I'm getting right now in the consults is the economy ready to reopen? And when we don't know who are asymptomatic, that becomes a problem because we don't know if they're going out and exposing others. So we still kind of encourage the physical distancing for that reason. And also idea of good hygiene and good disinfectant and cleaning of surfaces. So I think we still need to be very aware and alert of how to be in that environment and that mentality until we get a better idea how to trace and contact those who are asymptomatic carriers. And the reason why we don't know that right now, it goes back to my initial talk about the virus, is that we don't know how much viral load is in the body because we're not testing it, number one. Number two, we don't know at what level do they become infectious. So if we don't know if they're infectious enough and they're walking around without a mask or they're coughing, and as we saw earlier, some of these can travel quite a distance. We are exposing those unknowingly. So I think it still exists. Another good historical corollary is the TB exposure, consumption in New York City, same place. They had public health mandates that said, look, don't spit in the street, because we know TB is quite contagious that way too. And they actually made arrests. And there's a whole big sort of article about sort of the illness as metaphor. And Susan Sontag wrote a great book about this, talking about, how do we address these public health concerns and where do we balance that with individual liberties? And at a certain point, where we are today right now too is, how do we avoid asymptomatics and stigmatizing those folks, but also how do we encourage folks to continue the good practices of good hygiene and public health quarantine measures?
So we've talked about the stress associated with having the virus out there. We've talked about the fact that there may be people like Typhoid Mary floating around. But an article I read recently said part of the problem with this pandemic is that so much of the reporting on it right now is what the writer of the article characterized as sloppy reporting on sloppy science. Are we cleaning up our act, at least with regard to the science, Kenji?
I think we are starting to. I like to be an optimist when I first think about things. And one of the great things about medicine and where we are today in the 21st century is that we share data. I mean, this is great. When you look at it from a global perspective, we were able to genetically map out and map the genome of this virus within a couple of months. In the past, we wouldn't have seen that. Not only that, but once it was mapped out, it was shared with the world. So within a few months, not only did we map out the genome, but the genome was shared with the countries around the world, whether it's in France, Italy, even in China, Taiwan, Singapore, Australia, US. We got together, UK, France, we got together, and Germans got together and say, let's share the data, make it public, and we're going to be able to develop tests to be able to understand what this virus is. And now, as a collaboration, we're going to develop the vaccine. And it's really healthy competition right now that really is amazing. But the science behind it is still not great. And as a physician, we're first and foremost need to understand and use evidence-based medicine. And unfortunately, not everybody practiced that initially. There's concerns in the beginning saying, oh, this is just the flu. We don't have to worry about this. No need to close the economy. No need for social distancing. And now we know with hindsight, that wasn't right. And the question is, could we have flattened the curve earlier if we had good science, good public health measures in place? Maybe, but hindsight's always 2020. So I think if we have good science and good sort of adaptation of data as we move forward and make medical decisions on, we'll get better at it. And then reporting of it in the media, we'll be able to report on good science and hopefully lead to better media as well.
Yeah, hi, Paul, can you hear me now?
Yes, you're back.
Hello? I'm back.
Yeah.
I'm back. I apologize. This segues into what the one point I was really interested in making is the stress of this whole situation is greatly it's dangerous, but it's the uncertainty that we're all living with. When is this going to be over? Will we get a vaccine? Is the person in the grocery store with me a carrier who's asymptomatic? What happens? We don't have a really effective treatment. The uncertainty is very hard on people psychologically, and I think is greatly adding to the stress of our current situation. Hello?
Let me try to bring this really to a workers' compensation issue that impacts on what I do or what my company does. So based on what we know today, so snapshot in time, and I'm gonna ask Kenji this first. If you were asked to consult on a compensable COVID-19 case, so the compensability is out of the way, they've determined that the person's compensable, and the person was thinking about settling their case, and in order to settle the case, they wanted to know what the future medical exposure would be. How would you evaluate that person, what we know today? What systems would you look at, and how would you go about predicting what the future potential medical exposure would be within those various systems? Not a simple question, but I'm sure you can handle it.
I love the challenging ones because it makes me think. So it's hard. If you asked me this a month ago, my answer would have been not much. But just within the past couple of weeks, we've started to learn there's neurological effects. A lot of people have asked me about the smell and taste disorders that are developing there. We have good diagnostic modalities now. They're very objective in testing for smell and taste loss. And we just did one a couple of weeks ago that was to be published hopefully this week sometime through the Smell and Taste Center at Penn. And we know now there's neurological and anatomical deficits that occur from the virus itself. We also know there's good cardiovascular diseases that can occur because of the way that the enzymes occur that are affected, the ACE enzymes that are affected in the heart and the lungs. We medications that affect the heart in that way, and some people are using it for treatments now. Definitely respiratory as well. It's the third sort of modality I look at. So overall, for compensability in future medicals, my suggestion would always be do a good comprehensive exam, document what you see today, and potentially do blood work and also other testing modalities to document what you're seeing now that potentially might lead to future medical concerns. But that's not the total story because there's more to come. Right now, it's a moving target. We're always learning more data. Like I said, a month ago would have been a different answer. Within the past 2 weeks, we've learned now, even obesity is a risk factor and a comorbidity in some of these conditions we're seeing with people on ventilators. So as we learn more about it, the answer is going to change. But as of today, that's my suggestion. Comprehensive exam, focusing on the neurological, cardiovascular, and respiratory systems.
Okay. Do you think people
Paul, from the psychiatric standpoint, the course of the stress reactions is highly variable, and so it's going to come down to how is the individual done over a reasonable period of time before you can assume maximum medical improvement. It's going to be highly individual.
Okay. We've got some questions. Why don't we go to our questions? I'm delighted that the folks out there who are listening to us have taken the time to put together a question. Here's a question. Please talk about PTSD for the individuals that were ventilator dependent and what the appropriate type of care would be. So I think that falls within actually probably both of your areas of expertise. Lyle, why don't you deal with that first? Please talk about PTSD for individuals who are ventilator dependent.
The experience of feeling you're suffocating is awful. It's terrible. And if the person is having intense memories, nightmares about being suffocating, being in the ventilator, that can persist in the form of nightmares, intrusive memories, etc. You do treat it just like you would any other situation with PTSD. We do have some interventions, medications, therapy, cognitive behavioral treatment, eye movement desensitization type things. The response to treatment is variable. We just have to do the best we can.
Kenji, any comments about somebody who's been ventilator dependent and how that affects them after the fact?
Absolutely. It's quite traumatic. When I was doing a trauma call, It's always 2 or 3 in the morning. When we have trauma cases come in, we need to ventilate them and intubate them. It's challenging. It's quite traumatic, not only to your upper respiratory system, potentially your vocal cords. It's depending on how safe it is. And we see a lot of people that we'd send to dentists because we crack some teeth, unfortunately, while we do these intubations. So there is a lot of different sequelae. And from a medical perspective, I agree completely with Lyle. You know, we see a lot of acute stress disorders thereafter. I just remember PTSD is something you can't diagnose immediately. There's, you know, different DSM-5 definitions for it within 30 days and whatnot. So some of the acute stress disorder definitely is challenging, and hopefully with early intervention, we can decrease some of those translating to PTSD down the line. So we want to see that as we discharge patients from the hospital, especially post-ventilator dependent disease processes. So I want to look at the whole body overall, see what the conditions were, how do we treat it, especially if they're in there for infectious lung disease, the mucosis that we see because they're scarring in the lung. There's also conditions, maybe they're having a hard time breathing now, getting less oxygen to the brain. So there's other medical conditions. We gotta make sure we take care of the whole body as a whole.
Kenji, this one I think fits right in your scientific presentation a short while ago. Our questioner says, are there different strains of COVID-19? I asked that in the context of trying to prove causation. Was the exposure work related? So was it this virus in the workplace and a different virus someplace else? I've added that last part.
Yeah, no, that's a good question, right? That's why when Paul asked me about presumption, it takes that away. It just says, hey, if you're in this work class, it's presume you have it. It avoids having to do these analysis, because you're right. I talked about the virus having different mutations. So there is a lot of different COVIDs. There's not just COVID-19. There's one in 2003, potentially one in 2000, different strains that can mutate over time, and different vectors that they came from can have different signatures as well. So we do have analysis now that we can do to show the specificity of what that virus exposure was. So if you're in a scenario where you need to prove directly, was it this virus that caused it or not, it'd be nice to do a string of tests. And we used to do this in the first week or so of the pandemic in the US. Was we not only tested for COVID, we also tested for all the other viral diseases like respiratory RSV, we're testing for influenza, we're testing for all these whole panel of different viruses. But then we stopped that because we knew coronavirus was one of the prevalence that's sort of affecting the US. So we may have to go back to doing that in occupational health. And especially in what we do, it's very unique. It's not what CDC recommends, but unfortunately, just like Lyme disease and tick exposures, we have to sometimes deviate from what CDC says, but do it cautiously with some good medical evidence as to why certain occupations might require us to test more than just COVID-19 strain, but potentially test for influenza, test for RSV, and potentially other viral strains that potentially can cause these kind of similar cold or flu-like symptoms.
Okay. You alluded to your medical training, and I'm going to ask both of you a completely off-the-wall question that recently arose in my family. And full disclosure here, I'm married to a physician. My youngest son is a physician. So the question is, when you were in medical school, did you learn how to wash your hands?
Yes, in the surgical rotations.
Yeah, I started my career in surgery, so yes, we learned how to scrub our hands appropriately, wash our fingertips. But in general, you would think, right, that we should. That's one of the first things we learn about. But if you look at the curriculum overall, when we're talking about hygiene, preventive medicine, lifestyle medicines, it's very minimal in training and an understanding of what that means in a medical school setting. So I wish we had more.
I would totally agree with that. Unless I was going in the OR, I rarely wash my hands. And there were no sanitizers around back then.
Yeah, the other thing I learned is that the dirtiest part of your hands when you get done washing them typically is the dominant thumb. You usually don't pay attention to that as you're scrubbing. Anyway, I digress. I've got a question here about telemedicine. Can you address how it is flawed in any way when trying to determine impairment per the AMA guides? We are concerned that when claimants get placed at MMI, that their impairment ratings are not accurate when being evaluated in a telemedicine appointment. Kenji, maybe that's up your alley.
Yeah, so I think it depends on what the condition is for the telemedicine evaluation. I agree. If it's an exposure case where you need to see, feel, chronic regional pain syndrome is one. You want to be able to touch a skin and see if it's really warm or not. It's hard to do that through telemedicine. So it's one of those things where you need to do a good clinical or physical exam and document various things you can't see through the camera. It becomes a little more challenging. So this is where I want to clarify sort of what telemedicine means for some people versus telepresence versus telehealth versus digital health.
Okay.
There's a whole bunch of different definitions for that. But I think overall, we need to really be specific to what that condition is, because you're right, there's some conditions that it's really hard to do, and Lau mentioned too, psychiatric conditions are really hard to do through telemedicine. So it varies, and depending on what you're doing the impairment rating for, I would agree, you need to be very careful and review the record carefully before accepting these telemedicine consults as a MMI evaluation. Like I said earlier, if it's musculoskeletal, I think that's easier to do through telemedicine.
Actually, Paul, I'd like to weigh in on this because this is a pet peeve of mine that my colleagues rarely do a functional assessment. And functioning is the issue with disability, and it's relatively easy to do and straightforward in psychiatry. You just ask the person about their management of self-care. Do they get dressed every day? Do they shower? Do they take care of their home environment? Do they socialize at all? On and on about just general functioning as affected by their mental functions, depression, low energy, lack of motivation, etc., or psychotic symptoms, whatever. It's actually quite straightforward and very revealing when you question a person about how they're doing with these basic functions. It can be embarrassing for the person to admit they're not doing much.
Yeah, and I want to add to that too, because I think that relationship you have as an evaluator or as a physician, that doctor-patient relationship is very different when you're doing telemedicine versus in-person evaluation. And I think it comes to not only the human psyche, but the pheromones too. We actually wrote a really brief book chapter on this about human pheromones, and we missed that with telemedicine, telehealth, and especially in workers' comp. If you look at different providers and measure their sort of performance levels, the differences between one doctor and another is not that much unless you look at some of the likability factor of the physician or the provider that you're seeing and case closure rates. There's a good correlation between the two, but some of it is all about personality, interaction. You miss that sometimes with just the telemedicine piece because you can't see them, you can't smell them, you can't sort of get that sense of trust factor that can develop through a video that's very different.
Yeah. Here's a question that I think I may even be able to answer. It's the easy one. It's not an easy question, but it's a question I think it's more legal than it is medical. And the question is this: should these cases be litigated as injury or occupational disease claims? So I think the question is, should they be litigated under a traditional Workers' Compensation Act claim, or should it be an occupational disease claim? And as an attorney, let me answer that question. Workers' compensation, for the most part, has been around since the early 1900s. It wasn't until the 1940s that they started dealing with occupational diseases. And when they dealt with those, they had to be a disease that was unique to the person's profession. So black lung is the classic example. You don't get black lung if you're working as a physician at a hospital or if you're working as a first responder, but you do if you are a coal miner. And so I think these cases would be very difficult to prove in today's day as an occupational disease claim, unless, of course, they're a first responder, they're a person in a hospital emergency room or a physician, and this virus becomes part of the norm of what they're being exposed to. Would either one of you gentlemen want to weigh in and comment?
Yeah, I'm not sure if Lau wants to say something, but let me see if I can pull up this slide here, because I want to talk about the idea of occupational risk. I think if you think about it from a risk perspective, these different occupations, I'm not sure if you can see this or not, it's a little small, but basically this is a good risk score that looks at different people of what their income level is and what their degree of risk is in regards to being exposed. I agree with Paul 100%. You know, from a legal perspective, I think the analysis is pretty clear. From medical, it's a little more challenging when you're talking about viruses that can adhere to surfaces within 24 hours to maybe even 5 days if you're on a cardboard surface. So if you think about it from a Amazon or a postal worker who's handling deliveries right now, the virus can live on cardboard a lot longer than hard surfaces where we're disinfecting. So if they're in those kind of work environments, how do you assess that injury, whether it's an occupational disease? I don't think so, because the virus can be almost anywhere now, especially when it's community-wide. And as the prevalence rate increases, it definitely clearly answers that question. So the question that becomes is, what if you're in sort of this upper right corner, like a dentist or hygienist or someone who's acting and working with aerosolized material all day long, like an ENT physician, versus those who are sort of in sort of other disinfectant area, janitors or environmental services. I think those exposures are very different, but regardless, it's not something similar to like silica or asbestos and various mesothelioma developed from those exposures. So I would agree, Paul. I think even from a medical perspective, I would say that we should focus on some of the medical conditions and look at it from the traditional workers' comp injury side.
We have about a minute and a half left. Let me leave you with this question. I'd ask that you both comment on it, and that is, how is your world, that in Kenji, in your world of occupational medicine, Lyle, in your world of psychiatry, how is your world going to be changed as a result of this COVID-19 pandemic? Lyle, would you like to go first, please? Uh-oh. Kenji, why don't you weigh in on that?
Sure. I think from an occupational medicine, occupational health perspective, it's going to be a new norm. And I think the new norm is one that employers are starting to see the value of telemedicine now, telehealth. I think in Maine especially, and I think it's under your guidance, Paul, where we actually had workers' comp fee schedule that allowed for some telemedicine before a lot of other states. So we did it traditionally on a telephone, and some other occupational health vendors now offer the telemedicine packages for the past couple years. And the data that they're starting to support that the case closure rate has increased, same quality of care, and the cost has gone down. So I think from those three perspectives, if you're looking at value based on cost, benefit, and risk, we are seeing improvements in that area. The second thing is looking at how we respond to disasters and crises. I think that's going to change how and the value of occupational health. This is the first time I've seen CDC media actually address occupational medicine as a field. Most people didn't know what I do. People like occupational therapy. I'm like, no, I do occupational environmental medicine. So I think it's an opportunity for us to really shine what we do in preventive medicine as a subspecialty and specialized training in occupational environmental medicine. So as part of my role at the American College of Occupational Environmental Medicine, it's our time to shine and really be able to help the economy restart itself and also be able to help employers get employees back to work in a safe and healthy way.
Paul, can you hear me?
Yes.
Paul?
Yes.
Okay, just a quick response. We're out of time. One thing I think this is going to, how this will affect psychiatry is that the telepsychiatry and telemedicine is going to be helped a lot, which is important in psychiatry where there's a tremendous shortage of psychiatrists, especially in the smaller communities.
Thank you. We are out of time. Gentlemen, I thank you. You were wonderful. It's good to have you as friends, but it's better to have you explain to me what this world is going to be all about. So we're all over with our seminar. Thank you very much. Lyle, take care of yourself. Kenji, take care of yourself.
Thank you. Thank you, guys. Yeah, you
Bye,
guys, everybody.
Bye.